Welcome to our May K-12 seminar. This is our final seminar before we take a break for summer. And as always, I'm Lauren Baker. I am a K-12 scholar from UW-Madison. I am honored to introduce our speaker for today, Dr. David Bayne. Dr. Bayne is currently assistant professor of urology at University of California, San Francisco, where he specializes in kidney stones. He obtained his bachelor's degree in biochemistry from Harvard College and his MD from Harvard Medical School. During his residency training in urology at the University of California, San Francisco, Dr. Bayne also obtained a master's in public health. Much of his research focuses on health disparities in kidney stone disease, assessing the influence of socioeconomic status, access to providers, and surgical care on kidney stone outcomes. He also has a strong interest in patient clinical and demographic factors that influence kidney stone presentation, treatment, and outcomes. Today, he's going to talk to us about the influence of kidney stone size on the kidney stone treatment cascade. So we hope you all enjoy it, and please take it away, David.
All right, thank you for the introduction. So I wanted to first of all start by saying thank you for the opportunity to speak to you all today. It's an honor to be here, albeit virtually. And today I'll be talking to you about kidney stones. The title of my talk is Big Stones, Bad Access, Insight into the Kidney Stone Treatment Cascade. So I have no disclosures to report. And to orient everyone, I'll begin by discussing my early exposure to advanced stone disease during medical school, how this shaped my interest in kidney stone epidemiology, and led me to focus on the care pathway for kidney stone patients, as well as challenges and opportunities in future work in this area. I came across my first giant bladder stone while I was working as a surgical coordinator for Partners in Health in Haiti. Shortly after the earthquake in Port-au-Prince in 2010, I got some funding to spend 9 months in Haiti during medical school after completion of my clinical rotations and prior to applying for residency. And I remember when I first saw this x-ray, I was amazed that a stone could grow so large in a human being. And for many patients like this one, they had to travel halfway across the country through unpaved roads with many days waiting to find a surgeon. And in Haiti, this patient would be lucky because in this case, his stone was in the bladder and not the kidney. In fact, many people with large stones, staghorn stones in their kidneys, were turned away from care while I was there because only 1 or 2 surgeons in the entire country felt they had the expertise to do anything other than an open nephrectomy for patients with large kidney stones. As many who treat kidney stones already know, large stones are often seen in urology clinics in the United States as well. This patient has a large left staghorn stone. And as a resident and fellow, I was always curious to see why some patients came in with large stones in places where medical resources and surgical subspecialists were plentiful. For the non-urologists and non-clinicians listening, let's start first with a brief explanation of the downstream consequences of large stone disease. So first, bigger stones mean more invasive surgical procedures. According to the American Urological Association and European Urologic Guidelines, as a general rule, endoscopic and non-invasive techniques should be reserved for stones smaller than 2 centimeters. This means that people with larger kidney stones will more often than not undergo the more invasive percutaneous kidney stone surgery procedure. In cases where this technique is not available, they may require multiple shockwave surgeries or endoscopic ureteroscopy procedures. This means higher morbidity for these patients in the form of increased transfusion risk, complications, and or risk of multiple anesthetic procedures. All these patients end up spending longer time in the hospital on average as well, and it's no surprise then that the average PCNL procedure, the percutaneous procedure, is a more costly procedure than the less invasive options that are still on the table when the patients have smaller stones. So Why do some patients have larger stones? The classic teaching is that large stones are staghorn stones caused by infection from urease-producing bacteria. So they're struvite stones. They have a higher incidence in women, likely due to higher rates of urinary tract infections. However, there's in recent years increasing acknowledgement that not all large stones form in the presence of infections. And as a resident and fellow, I couldn't help but notice that, like the patients I saw in Haiti during medical school, the patients coming to our clinic with large stone disease were more likely to come in with some obstacle to getting care, whether it was coming from far away, being in marginal housing, or some other social medical issue causing delay. So I wanted to understand the relationship between a patient's social factors and their stone size. With the help of the Registry of Stones of the Kidney and Ureter, I looked through our recent UCSF data to determine whether there were any social factors associated with kidney stone size in our clinics. For those who are not familiar, RESCUE is a prospective patient data registry started by Dr. Chi in 2015 with the support of the NIDDK P20 funding mechanism. So for this study, we set our size cutoff for stones greater than 2 centimeters, as this is typically the guidelines-based delineation between PC&L procedures and other less invasive treatments. So among patients presenting with new visits to our clinic, we found that when controlling for all other potentially predictive variables, including age, gender, race, language, history of prior surgery, comorbidities, and other sociodemographic factors, only a BMI greater than 30, education, low education, infection history, and large travel distance was associated with a significantly higher odds for stone size greater than 2 centimeters. And when looking at these patients who underwent surgery with us and for whom we had stone analysis data, non-calcium oxalate stones, residents in a county with fewer than 2.5 urologists per 100,000 people, and a low median family income predicted for larger stones. In fact, in a follow-up study, we found that coming from a county with less than 2 urologists per 100,000 people predicted for a high cost independent of other clinical factors. Similar findings were demonstrated by Dr. Nakata's group at the University of Wisconsin. They found that patients from distressed communities were more likely to present with larger stones requiring PC&L procedures or stage surgeries. The Distressed Community Index is a composite zip code level quantification of employment status, education level, poverty rate, median income, business growth, and housing vacancies. So we've explored this dynamic further, looking at the impact of socioeconomic status on long-term treatment course for patients at UCSF. We were curious about the relationship between community food access, income, and surgical treatment for kidney stones. With collaboration from the UCSF Dream Lab, we were able to obtain census tract data on UCSF patients from 2011 to 2020. We found that patients from low-income census tracts were significantly more likely to require multiple surgeries for kidney stones. This Cox regression depicts probability without a second stone surgery over time in days. And you can see that the blue curve representing patients living in low-income designated census tracts are much more likely to require multiple surgeries for stone disease over time relative to the yellow curve, which represents patients from non-low-income designated census tracts. So when also taking into account the availability and density of healthy food sources, only low census tract income was a significant predictor of multiple surgeries for kidney stones. We wanted to see if we could find any association between social factors and large stone disease in larger data sets. However, one of the downsides of larger data sets is the disappearance of the granularity in the data, specifically around imaging. So stone size could no longer be assessed, and instead we had to use a proxy. We were able to see quite clearly that of the over 168,000 patients who underwent stone surgery in the California data set, Medicare patients and uninsured patients had a larger percentage of patients undergoing PCNL, which, as we know, is typically surgery reserved for larger and more complex stones. These patients are also more likely to have an additional surgery within 1 year of their first stone procedure, here too suggesting larger, more complex stones requiring more procedures for stone clearance in underinsured patients relative to patients with private insurance. These findings were also confirmed in the national data set of the American Urological Association. It's their AQUA database, which is the American Urological Association Quality Database. It includes over 243,000 patients undergoing surgery for kidney stones. Here too, Medicare patients are also more likely to have PCNL as their first stone procedure. And keep in mind, these studies control for gender, race, comorbidities, age, and multiple other demographic factors. So at this point, we've shown good single center statewide and national data suggesting large stones, more invasive surgery, and or stage surgeries for stones are more common in patients traveling further for their surgical care, patients without insurance or with government-sponsored insurance plans, or patients from low-income areas. Together, this data points to increased delays in treatment for kidney stones, causing larger stones in these patient groups. The simple surgeon's framework for looking at just diagnosis and treatment underemphasizes the multiple steps necessary to get from diagnosis to stone surgery. The steps in between diagnosis and surgery can't be overlooked and represent high-risk time points where patients can be lost to follow-up or experience significant delays in their care. HIV providers have been leaders in characterizing the treatment course for their patients. This figure numerically depicts the HIV care cascade, where we can see the number of HIV patients at each step in their care engagement from the time of infection through to diagnosis, to linkage to an HIV care provider, to antiretroviral therapy, and an undetectable viral load. This figure depicts the breakdown of the HIV treatment care cascade, in which individuals are tracked through discrete steps in their care. This has served as a powerful tool to conceptualize where patients experience obstacles in the treatment pathway. So borrowing from this model leads us to a more detailed concept of the kidney stone treatment course, with the potential to identify key steps involved in making it from diagnosis to completing treatment. This is simple and intuitive, but it highlights the importance of going from diagnosis of kidney stones to a subsequent visit with the urologist, and after surgery, the importance of follow-up and ongoing stone prevention, especially in patients at risk for more stones in the future. So to look at the time course of stone disease treatment, we looked at longitudinal patient data in our California and our national data set, OSHPD and AQUA. OSHPD contains patient emergency department and surgical claims data, and AQUA contains patient urology clinic data and surgical claims data. This allows us to study the relationship between time duration from first ED visit in the data set with stones and then the time of first stone surgery. And it allows us to study the relationship between the duration from the first urology clinic visit and the time of first stone surgery. In our California data set, we found that as time from the ED visit to surgery for stones increased, the risk of getting complex surgical treatment increased, even when controlling for patient demographics, comorbidities, insurance, and distance from the ED to the surgery center. This time increase was dose dependent as time increased in a dose dependent fashion with increase in odds ratios for complex surgery. However, in AQUA, we found that as time from the initial urology visit to the time of first surgery increased, there was no increase in risk for complex surgery between those two time points. So this data together suggests that time from ED surgery, from time from the ED diagnosis to surgery is associated with increased odds of complex surgery, while we're unable to show an association between increasing time from urology visit to the time of surgery and increased odds for complex surgery. So this has focused my interest in the time from stone diagnosis to the time of urology visit. Taking a step back, the socio-ecological model for social determinants of health highlights the complex interwoven dynamics of social factors and healthcare pathways. By narrowing on a segment of the care pathway, we can focus our investigations with an easily characterized outcome, in this case, the presence or absence of a clinic visit to the urologist. However, in order to best study and understand all of the factors that influence even a small segment of the care pathway, we must harness the full power of the data available to us. So there's a huge untapped reservoir of data available in the EMR or electronic medical record. By making use of this data, it requires skills in high computation and machine learning. And this highlights a desire, future direction for my career. I think there's a tremendous opportunity to leverage the volume of both data in the EMR to better predict care pathways of our patients, to be able to target efforts to these patients most at risk for a bad outcome, in this case, failure to progress in their necessary treatment course. This model is being used out of our county hospital to assign a risk score for readmission after congestive heart failure exacerbation. I borrowed this slide from my colleague, Dr. Zaire, who's a cardiologist at San Francisco General. He and his team are incorporating social determinants data from both patient report and inferred social determinants data from hundreds of traditional data points in the EPIC chart that are related to the patient's social circumstances, including quantity and read rate of social worker notes, smart integration of demographic information, date of last PCP visit, and even non-intuitive information like skin breakdown on admission that would have never been identified without the power of machine learning. These predictive algorithms identify high-risk patients for a particular outcome, in this case, readmission for congestive heart failure before the outcome takes place, and it targets social support for these most high-risk patients. So the question is, where do we go from here? We know that large stones and multiple surgical procedures are more common among patients who experience care delays and have barriers in care access. Given the strong association between patient social factors and advanced stone disease, I hypothesize that numerous points of traditional and non-traditional social data can be derived from the EMR to generate predictive machine learning algorithms to better calculate risk of care pathway delay from stone diagnosis to urologist visit. I think that this work will lead to opportunities for targeted social support for the most vulnerable patients prior to care progression failures. And this has been demonstrated in other disease care pathways like congestive heart failure. So I wanted to thank and acknowledge Dr. Chi and Dr. Stoller, as I owe a great deal of to both of them as my NIH career mentors. They, in addition to Dr. Susskind and Dr. Bivens Domingo, have served as vital mentors in my K-12 work to this point. I'm not able to fit all the names on this small slide, but I also wanted to thank my mentees for their hand in work and support with their research and other projects. And with that, I open the floor to any questions. Thank you.